Uh, in case some of you guys don't know me, which some of you guys probably do not know me, I'm Michelle McCarthy. I supervise the outpatient team at Northgate and do a little bit of this and that. It's nice to see some of you guys. I've never seen some of you guys before. Other of you I know quite well. Please feel free to ask questions really at any point. You don't have to wait until the end. If there's something that you just need clarity on, you can chime right in. If you raise your hand, I probably won't see you. But if you want to just unmute and say something, go for it. Or if you want to write something in the chat room, you can do that as well, and I will address your questions. So I'm going to share my screen and show you guys a couple of things. I will send out the stuff that I've typed up. I'll probably disperse it to managers and let them disperse it to you guys because I don't really want to collect all your emails and have to do it that way. But I'll make sure that you get it. We'll start with just going through the discharge summary process. So I'm assuming everybody here has done a discharge, has seen a discharge. If that's not the case and you're really super confused, I'll do my best to make you less confused. I typed this up so that it can be sent out to you guys, and it has basically step-by-step what you should be doing. So I'll go back and forth between the actual, this is just a actual discharge summary that was done.
Michelle, I have new staff on deck who has not done a discharge summary.
Okay.
So if you could show the discharge summary, I'd appreciate it.
So this is the discharge summary. Unfortunately, I cannot enter the training domain. I can't actually go into Credible and open a discharge and show you step by step how to actually go in and fill it in, because I can't get in the training domain and I'd have to use a real client to do it in the real system. But this is what it looks like when you're in there. You'll just have drop down boxes to select these things. So starting at the top, it's going to ask you what the type of contact is. Just make sure it's accurate. If you're doing it with the client in person, then sure, that's face-to-face in person. Most of the time we're doing discharge summaries not face-to-face with the client, especially these days. If you're doing a discharge summary when you are processing the discharge in the last session, then you could do it face-to-face, virtually, or in person. A lot of the times we're doing discharge summaries when we're not even meeting with the client. So choose according to what's actually happening. For the program, just make sure that you choose your program, the program that you're discharging the client from, and do not choose any of the programs that begin with a number. So when you click the drop-down list, the first several all have numbers in front of them. Please do not choose those. Go down. It really should be something simple like MH outpatient, case management. If you're ever confused, you can ask your manager what the program should be from that list. So program start date, date of discharge, and date of last service. There's some confusion on some of these. So the program start date would be the date that they completed the assessment to enter that program. Not the date that they were referred, not the date that they first called and asked about it, not the date that they had their first session, or billable contact for case management, but the date that they did their assessment. The date of discharge really should be the date that you are typing up this discharge summary. And then the date of the last service, it's the last billable contact that we had for outpatient. That could be a little different for other programs, but I only approve outpatient discharge summaries. So for you guys in other programs, you might have some questions that you have to take to your actual supervisor. But for outpatient programs, SAOP and MHOP, the date of the last service is the last billable service that we had with them. So typically going to be a session. It's not the last session scheduled, but they didn't show up. It's not the last time you talked to them on the phone. It's going to be that last actual service provided. And then we have our simple questions. Is it a discharge from Cove or assisted living? I mean, it's no, unless it is. Their basic information, gender identity. Does the client participate in the representative payee services with Western Tidewater? It's a yes or no. So the program or person to whom discharge, this again is an area that people are confused about, but it really should be the client, or if it's a child, it can be the client's guardian. Please put their name, their phone number, and their address. Please don't leave this stuff blank unless we don't have the information, which we should. Okay, so this is where the meat of the discharge summary starts. The reason for admission to program or presenting problems. So you guys have choices on what you do here. And again, I will send this to you so that you guys have a good example. If you want to just copy and paste information from the assessment into this section, you totally can. This example, this discharge summary example did that. The only thing that you absolutely have to do, if you're going to copy and paste some of the presenting issues from the assessment, please put something like the following was reported at admission to services. The following was taken from the intake. Don't just copy and paste the information and not preface it as this came from that assessment. If you don't want to copy and paste something from the assessment, you can just type up a few sentences, even just a couple sentences, just briefly explaining what led the client to seek the service. So Jimmy requested outpatient counseling services due to increased work stress and difficulty, coping with depressive symptoms. That's fine, as long as you give me an idea of why the client reached out for services or started the service. The reason for discharge, this really does need to be clear. So be specific about why the discharge is occurring. So it could be something like Susie has successfully met her treatment goals and no longer presents with the need for services, or Janae is being discharged due to not responding to a 10-day letter that was sent after she triggered the no-show policy. Whatever it is fine, as long as it's the truth and as long as it's clear why the client is being discharged. A tip for all of you guys, if you are specific in this section, especially when we're talking about clients who are discharging because they didn't respond to engagement letters or 10-day letters, then you can actually just copy and paste this section down at the bottom, which I will show you in this example right here. So right here, reason for discharge from the program. I wrote this with specific dates so that I could go down to this section. If contact was lost or if individual chose to discontinue services, please document efforts to re-engage in treatment. I copied and pasted from that section I just showed you down here because I already put in the dates and the efforts that we made to re-engage the client. If I had just typed up here, reason for discharge, Miss So-and-so didn't respond to a 10-day letter, that's not sufficient for this section down here because it wants to know down here. It says include phone calls, attempts, home visits, letters, and dates. Dates is important right here of the contact that we made. So the efforts that we made to re-engage in a specific way, not just Miss So-and-so was sent a 10-day letter, but Miss So-and-so was unable to be reached after her no-show appointment on 9/29. These calls were made on 9/29. That's probably supposed to be 9:30. and 10/1, and an engagement letter was sent on 10/6, to which no response was received. And then in this specific chart, I did see that final contacts were made on 10/18 because we were provided a new number by case management, but there was still no response. Does that make sense? Are there any questions so far? Okay. So does the individual have an active registration or authorization at Magellan? If this is outpatient counseling, the answer is no. We, for outpatient programs, do not have to get a registration or authorization with Magellan to provide services. For other programs, that could be yes, like case management. If you're not sure about your own program, I would say you should ask your supervisor, because I don't have all the answers for all the programs. The next one is summarize client's current level of functioning or functional limitations and continuing needs. It says if applicable, but please put something here. Do not put NA or unknown. Even if you haven't seen the client in a good amount of time, or let's say you only had a couple of sessions with them, please put something here. Example, current level of functioning is unknown due to client not attending any sessions within the last 30 days. Okay, like if you haven't seen the client in a month, you just don't really know what their current level of functioning is. That makes sense. Or you could put there's no changes in functioning since starting services, since the client didn't really attend sessions. That happens sometimes. This example discharge right here, I actually completed this discharge for a clinician who had left, but this client's 10-day letter expired after the clinician's last day. So I looked at their last couple of notes to get a sense of what their functioning most recently was. Really, it doesn't have to be super long, super detailed. If you know the client, if you've seen them within the last month, you should know something about their current functioning, about any of their functional limitations. So please fill this out appropriately. Summarizing the progress towards their goals and objectives. It says list each separately. Please put their goals and objectives in this section. You have to. You have to put their goals and objectives in this section. I just literally will put G1, O1, G2, O2, whatever, but then copy and paste the goals in. And then it's just like when you're doing an ISP summary review, type up a little bit about whether or not they made progress. Again, I did this specific discharge for a client who wasn't mine, so I did the best I could. But if it's your client, you've been seeing them, you should know something about whether or not they progress towards their goals and objectives. But if you do not copy and paste the goals and objectives into there, then I'm going to email you and tell you to, because now you know. You might not have before, so I was going in and copying and pasting them for some of you guys, but no longer. If the client did not engage in services, like they did an assessment, never had a session, or they only did a couple of sessions, it's okay to write something like the client made no progress towards any goals and objectives due to not engaging, but I still need you to put those goals and objectives in that section. I know it's tedious, I know it's a little bit annoying, but just copy and paste them, don't retype them. Yeah.
Michelle, I have a question.
Go for it.
With the goals and objectives area, okay, suppose the client declines services and you hadn't had a chance to even do the SSPI or the ISP, what would you put in there then?
Yeah, so we shouldn't be doing discharge summaries if a client never did an assessment. We don't need to do a discharge summary if a client never completed an assessment, because there's nothing for them to be discharged from. So if you've been doing discharge summaries for clients who never completed an assessment, it didn't hurt anything, but you don't actually have to do it. So that might help you out.
So if they're assigned to MHOP, then it'd be left up for your manager to unassign them?
Absolutely. Yep. You would just email
Okay.
your manager and say, we made the appropriate effort to engage in an assessment, but they didn't engage. They need to be closed out to the MHOP program. And whoever that is can definitely easily close them out to the program.
Okay.
Yeah, that's a great question though.
Excuse me.
Yeah.
Does this only involve just SAOP and MHOP, or does it involve SACM as well? But you don't have to have a discharge summary for clients who never showed for an assessment.
I can only speak to the outpatient programs, so you should ask your
management.
What's
Michelle,
that, Justin?
It's the same.
It's the same for case management.
Thank you.
You're welcome. Okay, so summary of critical events. This is a section where I see just NA all the time or none, but that's probably not accurate. I'd say at least some of the time, if not most of the time. Critical events can be anything significant, anything noteworthy that happened while the client was in services. So they moved, they changed schools, they lost a significant person in their life, or a job, or a house, or they had a medical diagnosis that they found out about during services. Anything that impacted the client could have impacted services. If the client did an assessment and was coming to sessions and then suddenly they just dropped off the map, like that's a significant change that I might note here. Jessica was engaging in regular weekly sessions, but her engagement in services significantly declined around Christmas, 2020. I'm just spitting out things right now, but usually there's something that could go here. If there's not, there's not. But please do note things that need to be noted. Please don't just put an A and move on, when a lot of times I'll look through some notes and see that, the client just lost a parent, or there was recently a huge life change. That's a critical event, and that should be noted here. Okay, let me go back to what the actual discharge summary looks like.
Critical events, you consider getting the flu or COVID, or just something that, somebody gets sick and just doesn't recover in time enough to re-engage in services.
That absolutely, yeah. So we might think, oh, getting sick, whatever, that we all get sick. But if it impacted services in the way you're describing, then yeah, that would be something to note there. Okay, is this a discharge from REACH or regional crisis team? I mean, it either is or isn't. Please don't put yes if it's not. This stuff right here, this stuff is stuff that you should be able to find in the client info. So their education level, their school status, their employment at time of discharge, military status, type of residence, housing stability.
And Michelle, that information does not auto-populate. That is information that we have to make sure that we're putting in. Because I don't know.
It does not populate. These are going to be like drop-down boxes that you have to select the answers.
Thank you.
If that makes sense. You're welcome. Independent living status, arrest in the past 30 days, pregnant status, female with dependent child. All of this, I mean, you'll see the options. It's self-explanatory what the answer should be. The thing that you really should note right here is the SA information. So I put this here. I hope I explained it well enough, but if you have questions, let me know. Please make sure when you're going to fill out the SA information on the discharge summary that you include the primary, secondary substance abuse issues that are already listed in there. So here's an example. Johnny, I look into his client info and it says alcohol as his primary, marijuana as the secondary substance abuse issues. Do not take those out. Do not go into this section and put none. They need to still be there. Now, he might say, well, I don't use anymore, so we can change the frequency, but we're not going to not put those in. You can add a substance abuse issue in that was not reported previously, but do not take any out. Does that make sense? Are there questions? Okay. Well, I'm going to assume there's not questions. On the same note, please put them in the same order. So if alcohol was in his client info section as primary, keep it as primary. Don't just willy-nilly like, oh, I saw alcohol, marijuana, I'll just put them in some random order. They need to stay as primary, secondary, tertiary, whatever was already there. Does the individual take prescribed or over-the-counter medications? You should know if they do. If you don't know, if there's some reason you don't know, if you click yes and nothing comes up, then the answer is probably no. But if you click yes, their medications will populate. This is not something you have to go in and type all this stuff in. Thank goodness, that would be a pain. This is really important though. If your client is in psych services with us, Western Tidewater, then obviously the answer should be yes. But then when it says best practice is to discuss discharge with the physician first, was the discharge discussed with the physician? This answer should always be yes. There's no reason this answer should be no. I don't know what your specific manager or supervisor tells you to do, but for MHOP, my clinicians know that it's as simple as sending an email. In this case, Dr. Ignacio was contacted via an email to talk about the client not responding to contact attempts and discuss, is there anything else we should do to try and engage the client? Sometimes it's as simple as just saying, good afternoon, Dr. Kaiser. So-and-so has requested to be discharged from services due to meeting their goals. Whatever it is, you really should be informing, you really have to inform their doctor that they are discharging from whatever the program is you're discharging them from. And if you're outpatient and we're talking about a client who's in case management, it's also really, best practice to talk to the case manager about them discharging from outpatient as well. Okay, the diagnosis populates.
Can I ask a question, please?
You can, of course, ask a question.
So what if it's the event that the client, just like the family, wants discharged? Mm-hmm. Do we still need to engage with the physician, even though they have the right to say they don't want the service anymore?
Of course, yeah. So it's not necessarily that we're reaching out and asking, hey, can I have your permission to discharge? Or, hey, can you help me engage them? Sometimes it is as simple as just sending an email. I've done it before, letting Dr. Kaiser know, hey, this client, this family requested discharge from services and will be discharged. Just so they are aware, because otherwise they might not know. But that is a good question. So diagnosis populates on its own. Something should come up. If nothing comes up, then that's a problem, because they should have a diagnosis in their chart. Okay, but something to note, the at-risk SED, SMI, please choose the right thing don't choose SMI if they're not 18 or older. Don't choose serious mental illness if they don't have a serious mental illness. A good example is like major depressive disorder single episode. That's not an SMI. If you're not sure, if you're ever not sure, just reach out to your manager or a peer and ask. I mean, sometimes we're not really sure. Like, there's some people who they could have PTSD and it's not actually an SMI because it doesn't impact their functioning enough to be. So there's some like iffy, I don't really know. So if you're ever just not sure, just reach out and ask. Nobody's gonna laugh at you. We're all not sure sometimes. Recommendations. So please put something in the recommendations. Usually we're at least going to recommend that they continue with the services that they're continuing with. So for outpatient, a lot of times a client might have met their outpatient goals, but they still need to continue with their medication management, or they still need to continue in case management. So the recommendation would be that Miss So-and-so continues case management and medication management. Sometimes they're discharging because we lost contact. So the recommendation is that they re-engage in the service. Like this one, it would definitely be recommended this client get back into MHOP. And then sometimes we have recommendations for things that they haven't done yet. Like maybe we've met our goals in individual outpatient, but it's recommended that they begin attending group therapy to process grief or a trauma group or something like that. Whatever it is you recommend for the client at that time, just please put it in there. And then referrals, it's okay if no referrals were made. A lot of times we're not making referrals at the time of discharge because we're good at our jobs and we're usually making referrals throughout services. But if you're doing a discharge and at that time the client is asking for a referral for something, please put in the referral that was made. Pretty straightforward. These other questions, they're self-explanatory. Did the individual participate in the discharge planning? Sometimes yes, sometimes no. What date did we notify them of discharge? So if this is a client who I just had my last session with them because they, had asked to be discharged, I could have notified them of their discharge that day, or let's say we started talking about it a couple weeks ago. I'll just put whatever date it is that we agreed that they were going to be discharged. If it's a client we lost contact with, so they were sent a 10-day letter or an engagement letter, you can put the date that the letter was sent to them. If it was a client who you were trying to get in contact with and you kept calling and calling, you can just put the date of the last call where you said, if I don't hear back from you, you will be discharged from the program. The authorized representative participate in discharge planning. It should be yes if they have one. And then it's not applicable if they don't have one. It shouldn't be no, because that means they have one, but they didn't participate in discharge planning unless nobody participated in discharge planning because it was a loss of contact. Does that make sense? I'm trusting that you guys would ask questions if you had them, so. And then these last two. Okay, so it's an either or here. You're either going to describe the client participation in discharge planning, or you're going to describe our attempts to engage them because we lost contact, essentially. So, so if the client / family did participate in discharge planning, just give me a little bit about how that went. Client engaged in discharge planning during her final session and stated feeling confident in maintaining progress throughout, services. Client requested some information regarding local support groups. Whatever it was. If the client did discharge plan with you, what did you do with them? How did they respond, essentially? It doesn't have to be lengthy. It usually is very basic, so-and-so agreed to the discharge plan, so-and-so requested discharge because she felt like she didn't need services anymore, whatever it is. Put something there if you did discharge planning with them. If contact was lost, I talked about this before, but you really need to put the dates of all documentation, that all the documented efforts that we made to reengage the client. So you look in their chart, you look in their services list, you put, the dates of the phone calls made, the dates of the letters sent. Pretty straightforward. So here are some just general reminders. When you're doing MHOP and SAOP discharges, please do not select a supervising physician, because I have to go in and take it out because I'm the one who's signing them for MHOP, and Vonda's the one who's signing them for SAOP. And so when you guys put your own supervisors, I have to go and change that and take it out.
Want us to select you then, or just select nobody?
You don't need to select anybody. So the easiest thing is select nobody, because sometimes, like if I'm out, say Tanetta might be approving them for me while I'm out. So they automatically go through a multi-step approval process no matter what. So you just actually don't have to select a physician at all. So it makes it easier because you don't have to worry about it, and I don't have to worry about it. No one has to worry about it. For other programs though, I don't know. Your case management manager might have told you to select them. I don't really know how it works in other programs. So do whatever your manager told you for anything that's not MHOP and SAOP. For MHOP discharges, please make sure clients are not engaged in FFT with like Ashley or one of their clinicians before you do a discharge summary for the individual MHOP you're doing. So for the time being, FFT is still just being documented and billed under MHOP. So if I have little Timmy, and little Timmy is discharging from my services because he didn't respond to a 10-day letter, or his mom said we don't want it anymore, but I look in the chart and I see that Ashley is doing family sessions, then if I do a discharge summary, I just closed him out to Ashley unintentionally as well. So we do not do a discharge summary in that case. You'd actually do a non-billable note that just says that they're going to discharge or discontinue individual MHOP, but continue with FFT. It doesn't happen very often, but it did come up recently, so I just put it here. This doesn't apply to case management or other programs. For any discharges, please make sure that the services for the program that you're discharging them from are approved. I can't approve, or no one can approve your discharge if there's services that are unapproved, especially billable services. So it could be the case where you had a session 11/14, and that's the day that you agreed to do discharge, and then you went and did the discharge summary at the end of the day. That's totally fine, but I can't approve that discharge until that session, that note is signed off on. So if you're ever looking and you're going, why is this discharge summary not getting approved, and there's an unapproved service, that would be why. Obviously, if it's something like a note that needs, your supervisor to sign off on it, and give them some time to do that. If it's something non-billable or whatever, I'd probably just email you and ask you to go in and approve those. For all discharges, nope, I already read that, just kidding. Other than loss of contact, there needs to be something in the last note, the last, treatment note or non-billable note that indicates the client is being discharged. So Tammy calls me and says, I don't want services anymore. I got a new job. I just don't have time for it, whatever. If I go in and do the discharge but there's nothing noted, nothing documented about discharge happening, that's a problem. There should be a non-billable note that says Tammy called the clinician explaining she wants to be discharged due to having a new job and not having time for it. Or I have my last session with, I can't think of names today, John. And, John and I have been planning discharge and it's our final session, but it doesn't say that the client's being discharged, then that's not going to work. It needs to say, like at the end of the note where it says plan, you could just put John is being discharged, which the note content should also discuss that, discharge was processed. But anyway, you guys get what I'm saying, right? I don't hear any questions, so I'm going to assume that you get what I'm saying.